Thank you very much for the kind introduction, and thank you, Siripong and Kasidin, for inviting me here. It's really a pleasure to be here. It's the third time I'm here, so I've been in every RjPT conference, and thank you for giving me this topic, because it's not a technical lecture, which I will definitely be outshined by the previous speakers. So thank you very much. Now, I'm going to speak to you about nutritional intervention for colorectal cancer patients. I tweaked the talk a little bit. And this is my other passion other than colorectal surgery. So I have no disclosures. Now, this is the outline of my talk. I'm going to tell you how serious malnutrition is in colorectal cancer patients. What are the effects of malnutrition in patients with colorectal cancer? And how do we give nutritional support in the perioperative period? So that's a bit more of practically what we can do, and what can we do to improve nutritional care for our patients at the individual level, at the department level, and perhaps at the hospital level. I'll give you a case scenario. So you have a 72-year-old lady. She comes in with a partially obstructed sigmoid tumor. She undergoes an emergency Hartmann's procedure. She has cancer, she's obese, she's malnourished, she's septic. Interestingly, the surgeon decided not to feed her, fasted her for a further 1 week with only giving IV drips. She had no vascular access, no nutritional support, so there's no nutritional intervention whatsoever. At the end of the day, she had a burst abdomen, she had bed sore, and she has pneumonia. And these are the common things that we still see in hospitals throughout, at least in my country. Perhaps not in the tertiary care centers, but outside in the smaller hospitals. And it's something that is a continuous challenge for us to remind our surgeons that you need to put in nutritional management in your surgeries. Now you can see that 2 out of 3 of our GI patients come in malnourished, and I'll show more data on that. And obviously, when they're malnourished, when you do a surgery, the complication rates are higher. Surprisingly, less than 20% of patients undergo screening at any level in the hospital. And because you don't screen, you don't identify, then these patients who are malnourished undergo surgery. They obviously have bad complications, and then you spend more money on them, and it's just not good for everyone. Now, this is a very quick audit we did in my hospital a couple of years ago, and you can see that in colorectal surgery, at least, up to 50% of the patients are categorized as severely malnourished. So it's a big problem, not only in general surgery, but also in colorectal surgery. Now, obviously, it depends on what kind of patients you get, and it's a tertiary center or not, but you know that the problem of malnutrition is significant. And depending on the type of assessment tool that you're using, it can range from anywhere from 20 to 50% or even more. Now, this is an interesting audit that was done by many of the surgical nutritionists in Southeast Asia and Northeast Asia, and you find that up to 80% of our critically ill patients are malnourished, especially in the elderly population where it's more. And obviously, the results is that these patients have higher surgical site infections, they have delayed wound healings, and pneumonia. Now, why is a surgical patient malnourished? Number one, they are, depending on the type of cancer, especially their head and neck cancers, they can't eat, for example, so that's why patients with upper GI cancers tend to get very cachexic when they come in. But even if they can eat, if the patient has some form of inflammatory bowel disease, short bowel syndrome due to trauma, due to an enterocutaneous fistula, then the absorption is less. Or cancer itself and surgery itself, depending on the severity of the cancer of the surgery, can cause an increase in metabolic demand. Now, when you're talking about malnutrition, I think there are many types. You're talking about macronutrient deficiency, micronutrition deficiency, and I think the emphasis that I'm going to put is on sarcopenia, which generally means a muscle loss, right? And that's what it means. And the importance of the muscle in surgery, it's not only about physical movement and strength, but it has a very important metabolic function because it's a main reservoir for protein. And you see that surgery causes catabolism, and these patients will inadvertently lose weight. And if you have to minimize the catabolism, that's going to happen. And if you lose up to 10% of your lean body mass, your total muscle mass, then you obviously will already have complications. And if you lose up to 40% of your total muscle mass, there's 100% risk of death. Now, you're not talking about muscles that control limb. Okay, these are muscles that also involve the muscle of respiration, and then these patients obviously will not be able to breathe properly. They are so weak, they have pneumonia, and they'll die. So this is a study that was looking at the effect of sarcopenia on patients undergoing colorectal cancer surgery, and especially in the elderly population, sarcopenia increases significantly the rate of infection rates and the delayed wound healing. And it's not only in surgery. If the patients are sarcopenic and you don't identify them and you don't manage them, then these patients also tend to get lower doses of chemotherapy if they need it. And therefore, in the long-term outcome, that is significant. So practically, what can we do? Now, we know that surgery causes inflammation. You need increase in nutrients. And if you don't give it, then these patients obviously have higher morbidity and mortality. And what's most important is that you need to give a continuous supply of these requirements. Now, I like to tell my patients that undergoing major surgery is like running a marathon. So you have patients who, because of their cancer, they have anorexia. They don't eat. They have not been eating for the past 2 weeks to a month. And then they undergo such a huge catabolic event like surgery, and nothing is done for them. So it's like asking a person who is starving for the past 1 week to go and run a marathon, and obviously the outcomes will be bad. So you try to, so these are the goals of perioperative nutrition intervention. And I'll base it on the latest ISPN guidelines that was published in 2021, and also for cancer and for surgery. And the first thing that you must do is you must screen. And this may sound obvious, but interestingly, and I will show data later, that it's not happening. And the easiest one that I like to use is NRS 2002. And I've included it in my new hospital, where I put it into the computer system where the nurses will do it. Because if they don't do this, then they cannot do any other thing. So nutritional screening is really part and parcel of the very initial assessment of the patient. And it's very easy. I think even a high school student could do it. But once you screen and the patient is malnourished, then obviously it needs a proper assessment by a dietitian, which surgeons don't have the time to do it, but you need to get your dietitians on board, right? And I'm putting this slide here because there are many ways to assess for nutritional malnutrition, for sarcopenia especially. Now it's impossible to do all this. Some of them are obviously not practical, but I think one of the things that you can do is when you're doing a CT scan and you're looking at the stages for the patient, then you can get the radiologist to try and measure the skeletal muscle index, especially if you're looking at the psoas muscles here, and then it can tell you what type of protein reserves or muscular reserves the patient has. Now, if you see the evolution of the ISPN guidelines on surgery, what they used to say, the weight loss of more than 10 to 15% within 6 months, the BMI of 18, they used to go to talk about serum albumin. Now, in 2017, they removed albumin out of the way, so you can't use albumin as a good indicator for nutritional assessment, but mainly the BMI and also the use of a fat-free muscle index. Okay, and in 2021, they added that you should start surgical intervention if the patient cannot maintain more than 50% of the recommended intake of more than 7 days. So when patients do not meet the energy needs from normal food, it is recommended to encourage these patients to take some oral nutrition supplements. Now, in my personal experience, if the patient's undergoing a major colorectal resection and they see me 2 weeks or even a week before, I will tell them to take some form of oral nutrition support. And I tell these patients to take ONS, think of it as medicine rather than as a supplement. Because a lot of patients, if you tell them it's a supplement, they might decide not to take it or not. But if you tell them it's a medicine, take 250 mils, take 4 scoops, put it in 250 mils of water, drink it twice a day, whether it's Glucina, Ensure, doesn't matter what brand you're giving, the patient will then tend to think that this is medicine and they take it. Obviously, before and after surgery for better outcome. And this is a study that you look at, you just give dietary advice alone. You actually tell the patient, just eat well, as opposed to actually prescribing oral nutrition support. And what it shows is that in patients who undergo colorectal cancer surgery, they do result in less surgical site infections. All right? Now, how much calories should you give? If you are in a very big center, in a critical care and ICU, you have indirect calorimetry. That's great. Obviously, it's not practical all the time. And you can use estimations. You can, I just had a chat with Isaac, in Singapore, and I'm sure in Malaysia, not many surgeons actually know how to calculate calories. They leave it to the dietitians, and I feel that sometimes the dietitians need to be guided by you because you are the surgeon. You roughly need to know how much calories you need to give, how much protein the patient needs, and then you can guide them because sometimes they either overprescribe or underprescribe. Okay, and these are the substrate requirements. Obviously, a normal person might need 0.8 to 1 gram of protein per kilo per day, but if you're undergoing major surgery, that goes up to 1 or to 1.2. So it depends. And you need to double check your dietitians whether they're actually giving it right. Now, this is a common question. Is preoperative fasting necessary before surgery? The anesthetist will say yes, it is obviously needed, but how long you need to fast is very important. And you may even give a clear fluid up to 2 hours, provided there's no risk of aspiration. And the reason really is because major surgery does contribute to insulin resistance. And insulin resistance, it's like diabetes. You have risk of infection, renal failure, macro and microvascular complications. But if you bring it to surgery also has insulin resistance. And the bigger the surgery, the higher the insulin resistance. And therefore, how do you minimize insulin resistance? That's why our previous speaker spoke about ERAs. There's so many things that we can do. But one of them we can talk about is preoperative carbohydrate loading, provided the patients are not diabetic, and that you can see between a normal sports drink and a specially designed carbohydrate loading readily available outside, you can see that the osmolarity of these drinks are much less. That gives some reassurance to the anesthetist. Otherwise, some anesthetists who are not aware might cancel your case if you were to give preoperative carbohydrate loading. Obviously, I'm not going to talk about this. Minimally invasive surgery, robotic, laparoscopic, does contribute to reducing ileus, reducing the stress, obviously the catabolism, and also the insulin resistance. Now, the next question, obviously, I think all of you know this. Should I stop oral intake after surgery? The general consensus is that you should try not to for very long. In fact, you shouldn't if you can. And you should try to start clear fluids as soon as you can, right? And if you look at this study, they randomized about 100 patients. They look at whether these patients post-operatively had nutritional supplementation or not. The patients who had some supplements obviously had a reduced weight loss, better strength, less complications. Now, what type of nutrition should you give? Whether it's immunonutrition or should you just give a standard high-calorie nutrition? This is a study that was done in Europe, or 6 Spanish hospitals. They all had ERAS protocols, and they divided, should they give a solution with arginine and omega-3 fatty acids or just a standard solution, and they found that patients who did receive immunonutrition had a significant reduction in complication rates. So the guidelines say, especially with cancer patients, you can consider if they are anorexic, and this very good, the oncologists usually give this, but I think as surgeons dealing with cancer patients, it's good to know that some amount of steroids does help in increasing the appetite, right? And also omega-3 fatty acids or fish oils in the immunonutrient drinks does help in stabilizing improving the appetite and the food intake, all right? I know Thailand is one of the few countries in Southeast Asia who does allow cannabis use. At least in the current guidelines, at least say that there's insufficient evidence to recommend it to be using to improve taste disorders or anorexia. But at least these are guidelines that are coming out. So in summary, when you look at a patient, the first thing you do is you screen. If the patient is mild or moderate and you need to do the surgery, go ahead and do the surgery. However, if they are mild or moderate, but the surgery is so big, you're doing a Whipple's, you're doing a major pelvic exenteration, you need to prescribe this patient something. Or if the malnutrition is so severe, you have to, if you can, obviously, if it's an emergency, you can't, hold on to the surgery, wait for 1 or 2 weeks, give some nutritional support, and then operate. Then after surgery, the first question you ask is, can you feed the patient? If the answer is yes, then you can use the mouth, fast-track surgery, ERAS protocol, that's great. If the answer is no, then you ask yourself, can I reach the target calories with enteral nutrition alone? If you can't, the guidelines say if the patient can't take up to 50% now, start parenteral nutrition. The next question you ask is, can you meet the energy requirements? If you can't, entirely from the oral route, then you have to start combining enteral and parenteral. At the end of the day, you have to target the number of calories. You've prescribed this patient, say 25 kilocalories per kilo per day, and you've calculated this patient needs, say, 1,500. The patient can't get that 1,500. You've got to give it somehow, either enteral or parenteral, right? And then at 7 days, you ask yourself, can the patient now take orally? If you can, start the parenteral nutrition. If you can't, you have to continue. Now, just as a very brief overview, what is awareness of nutrition? Now, this is a study that was done in my country, in Penang Hospital, a couple of years ago, and they surveyed about 300 over doctors on attitudes, knowledge, and practice of clinical nutrition in surgery. 70% of surgeons and doctors are just indifferent or ambivalent towards this. Even though majority of them knew a little bit about BMIs and what normals are, and they knew that starting nutritional support is important, only 30% of them screened, and more than half did not have any nutrition care protocol in their department. So I think what's important here is that you can't work in silos. No man's an island. You need to start a team. If you haven't had a team in your hospital, start it. Bring together your pharmacists, your dietitians, your physiotherapists, and start something. We've done that in the National University in UKM many years ago, which I headed, and I started the first nutritional support team in a private practice where I currently work. So the first thing is to institutionalize nutrition care management in your clinical practice. You've got to educate, start young, start them at the undergraduate and postgraduate level, formulate national guidelines if they aren't, and form nutrition support teams. So what can you do? Start small. Approach your dietitians, pharmacists, and senior nurses. Try to get them together. Obviously, you need to get administration on your side. Speak to your head department, speak to your medical director. Try to get management on your side, because if you try something without their approval, obviously you're going to get resistance. Start with screening. If you haven't started screening a patient, you should always start. And try not to be too ambitious. Try not to screen the whole hospital, because you get a lot of problems. Try to start with 1 or 2 wards first, and then you offer to mediate between teams and colleagues. Surgeons like to listen to other surgeons. They don't like to listen to dietitians and pharmacists. And if you can mediate between them, that'll be good. So what's the take-home message? The take-home message here is that the incidence of malnutrition is high among surgical patients. And malnutrition leads to sarcopenia. Sarcopenia leads to higher morbidity and mortality, right? You should, if you haven't, you must include nutritional management before and after surgery. Increased awareness among healthcare professionals is suboptimal, and we know that. And therefore, you need to educate our colleagues, start an MDT on nutrition, and so you can coordinate management. Thank you very much. Now, this is my hospital in KL. I'd like to invite you, if you don't already know, this is the Asia Pacific colorectal meeting in Kota Kinabalu, and we've got a lineup. Prof. Arun is invited to give a plenary, and we have William Chen, and we have Paul Sugar-Baker coming in to run a pre-congress workshop and talk about his experience with HIPAC. So please do come. We have it's not that far away. It's not very far. Unfortunately, you gotta transit in Kuala Lumpur. But for my colleagues in Taiwan and Korea, and there are direct flights to Kinabalu. And if you are interested in nutrition, we are also organizing the Parenteral and Enteral Nutrition Society of Asia meeting in Kuala Lumpur in November. So thank you very much.